Very good morning. At the outset, I am really thankful to the organizers for giving me this opportunity to be here and speak on this topic. So I'm sandwiched between the two great speakers. First was Professor Girish Gupta, and the new speaker coming will be our President-elect, Professor Sushma Nage. So it's a difficult task for me. But let's see what happens next. I think the time allotted was 30 minutes rather than 25 minutes, if I remember correctly. Earlier you said 25 minutes plus 5 minutes. Yeah, I will try to do it. Okay. So we all know nutrition has a major impact on short-term and long-term outcomes in newborn babies. But there's a lack of strong evidence in several areas of preterm nutrition. And many nutritional practices are based on low quality evidence with focus only on short-term outcomes, like hospital, length of hospital stay, time to take full volume feedings, late onset sepsis incidence, etc., etc. Observational studies, though they are very important source of knowledge, may yield sometimes false results, which ultimately may not stand the rigor of RCTs. If you look overall in medicine, half of the major trials, they are negative trials. That means the researchers started with thinking that something good is going to come out because there was observational data. But when they conducted large, well-designed RCT, the results were negative. So disappointing. So that is the tragedy and the problem with observational data. So we need high quality research which assesses not only short-term, but long-term functional outcomes like neurodevelopment at 2 years or 5 years or even longer. So the brief, my outline would be, I would discuss some nutrients. It's not possible to discuss all the nutrients. It's not a postgraduate or UG class where I have to capture the entire nutrition in 45 minutes. Sure, some critique on the nutritional practices. We have some small experience on preterm nutrition. And then we have issues in preterm nutrition, but the same is the problem in pediatric and adult nutrition. There's a lot of chaos and confusion. So can we learn from them? And I will have some of my thoughts. Let's see what happens. So Dr. Girish has already highlighted preterm babies, because they are born too soon, they have limited nutrient reserves. And because of growth requirements, they have high demand. So there's a mismatch. There's a difficulty in delivering nutrients because of their immaturity. And we have incomplete understanding of nutritional physiology. Many areas we still really do not know. And some of the nutritional practices, though we have good intentions, but they have a potential to cause more harm than good. In newborn babies, when we deal with very vulnerable segment of population, there is a principle that's first do no harm, primum non nocere. In being enthusiastic or over enthusiastic, I would say we should not lead to outcomes which are not desirable. Here I would like to quote this study, very landmark SIFT trial, SIFT trial, published in NEGM. Who would not agree that if you give higher about 30 ml per kg per day, daily increment, compared to 18 or 20 ml per kg, we all love it. And babies would be fine. But they found there was no significant difference in survival without moderate or severe neurodevelopmental disability at 24 months in these babies below 1.5 kg. The daily increment rate was 30 ml per kg per day versus 18 ml per kg or 20 ml per kg. 18 ml was enough. But at 24 months of age, there was an unexpected increase in the risk of moderate to severe motor impairment in the faster fed group. This was a kind of shocker to the investigators. That could be a chance finding when you do multiple comparisons. So it could happen. But there was a signal. Let's say that they would have stopped study at 6 to 8 weeks at hospital discharge. So these babies took shorter time to reach full volume feeding. And they would have published it. The 30 ml per kg you start on day one, or daily increment, or 20 ml per kg, 18 ml per kg. So they do very well. You can discharge them earlier from the hospital. Or maybe weight gain short term is better. But at 2 years, the functional outcome was same. There may be short term transient benefits, which may not be sustained on long term basis. And there was some signal that there may be some issues, like they found moderate to severe motor impairment in the babies who were fed 30 ml per kg, the daily increment. So we have to be a little bit cautious. The growth in utero, ex-utero differs. In utero, Dr. Girish has already highlighted. It's a kind of heaven for a fetus. And after birth, you have the typical NICU environment, handling pricks, infection, light, sound, lack of sleep, frequent pricks, bilirubin at 10 o'clock, blood urea at 12 o'clock, then consultant takes round ABG, and then not one prick, 2 pricks, 3 pricks. So now imagine the baby has to grow in this environment. So growth is a challenging task. It's not only the growing, but the quality of growth will be most likely different in a ex-utero baby compared to an in-utero baby. Fat-free mass and fat-free mass and fat mass are different. So there are issues in the growth. So what is the ultimate aim of preterm nutrition? The overall aim of the preterm nutrition is to have these nutritional recommendations which provide intake ranges that optimize nutritional status. Second, and very important, is minimize risk. And we should not undermine this the possibility. There can be unintended harm. And final purpose of nutrition is to improve long-term functional outcome. The final purpose of nutrition is not that baby reached 150 ml per kg per day by 7 days or 10 days, or baby regained birth weight instead of 10 days at 7 days. Very short term, very short term. So the second and third point is very important. Please focus on these points. Of course, without optimizing nutritional status, you can't achieve other things. But in the effort to achieve nutritional status, please minimize the risk, and focus should be on long-term outcomes, neurodevelopmental issues at 2 years, or whatever the case, 5 years or whatever. I will just focus on 2 or 3. Water is the major constituent of the human body and a key component of nutrition, important carrier of nutrients and metabolites. We forget that water is also a nutrient. Not only that, energy producing substances are nutrients. Sodium doesn't produce energy, but this is an important nutrient. So many other things, right? Of course, preterm babies have higher fluid requirements compared to term babies. The recommended intakes as per ESPGHAN 2022 is 150 to 180 ml per kg per day. Most stable preterm babies would do well with 150 to 180 ml per kg per day. Range is 135 to 200 ml per kg per day. So below 135 on a long-term basis, it's not a good idea because it's going to cause renal compromise and hemodynamic instability. And you will not be able to deliver adequate nutrients if the fluid intake is below 135 ml per kg per day. Most babies would be happy with 180 to 200 ml, upper limit. There's a one RCT where they compare 200 ml per kg per day with 300 ml per kg per day, published in Journal of Tropical Pediatrics from the southern part of the country. They found no difference, maybe better growth. I would be hesitant in giving 300 ml per kg per day. There are issues. Simple. See, the problem is if we conduct small RCT, we may find a difference, and we have not assessed the long-term outcomes. What happened to the babies at the age of 3 years, 5 years? Fluid intakes is also important. Remember, they are influenced by the milk composition. If you need to give higher proteins, then the fluid requirement has to be high because there are obligatory renal losses or the water. The solute load is high. So to exceed that solute load, you need to have more water, not less. So the prospective studies have demonstrated better growth with feed volumes up to 200 ml per kg per day. But long-term functional outcomes or different fluid intakes have not been studied. So that is an area of concern. In BHU, we will be happy 180 to 200 ml per kg per day, usual practice. Energy. The reasonable energy range is 115 to 140 kilocalories per kg per day. This is grade A recommendation by ESPGHAN. Most babies should be happy with this. And sometimes baby may require more than 140 kilocalories when the growth is faltering. But before that, you have to optimize protein and other nutrient intakes. And energy intakes should not exceed 160 kilocalories per kg per day. Otherwise, you can drive the baby to obesity, right? So aim for 115 to 140 kilocalories per kg per day. Protein energy ratio is also important. So 2.8 to 3.6 grams per 100 kilocalories is recommended. That energy and protein intakes are within the recommended ranges. Providing excessive energy without sufficient protein may lead to this problem. And providing too much of the protein without sufficient energy intake may increase metabolic burden and result in poor growth. This is important to understand. If you remember in nutritional sciences, there was a nutritional fiasco, what is known as, in 70s or 60s, being pediatricians, we know protein energy malnutrition. So before Gopalan gave theory of disadaptation for the causation of so-called kwashiorkor, the predominant thinking in those times is a protein deficiency, which causes malnutrition. So the name is protein energy malnutrition. But later on, Gopalan from Anna in Hyderabad disproved this theory, came the disadaptation. So people said it should have an energy protein malnutrition, or finally energy malnutrition basic. But the PM term has stuck up, right? So the protein fiasco was, the current understanding in 60s and 70s was if you give too much of the proteins, malnutrition will be less. But there was no difference. The babies were fat, and in fact, the mortality was more. I'm not talking of newborn babies below 5 years, those children who were malnourished. So so you have to be cautious. Don't give too much of the proteins unnecessarily. So protein intake 3.5 to 4 grams per kg per day. In the previous recommendation, the recommendation was 3.5 to 4.5. Now ESPGHAN say 3.5 to 4. Some babies may need, those who are not growing well, up to 4.5 grams. So they have shifted their gears from 3.5 to 4.5 to 3.5 to 4. And several recent randomized controlled trials performed comparing higher versus moderate protein intakes. They were conducted, and most of these studies were underpowered, and the protein intake is measured imprecisely. So difficult to draw conclusions. Data on functional outcome, that means neurodevelopment, is extremely limited. And though we have read about glutamine, important for gut health, arginine and taurine for brain health, but as such, they are not recommended. Theory is beautiful, but you need evidence, hard evidence to convince its safety and efficacy. Coming to protein intakes and blood urea, this is one area. There's a strong correlation between the protein intake and blood urea concentrations. And the levels may be used as a biochemical, not a good biochemical marker, but short of that for adequate protein intake. The target blood urea level should be between 18 to 28. and low blood urea levels may indicate the protein intakes are suboptimal, and you can go higher. On the other hand, if the levels are high, and if there is no fluid or renal derangement, then lowering the protein intake may be recommended. So ESPGHAN has given conditional recommendation to monitor blood urea levels to regulate protein intake at a regular interval. They have not mentioned regular interval, but I would say weekly. I will not monitor the daily unnecessarily, maybe weekly some, but it needs to be validated. I mean, it's not that it is something wonderful. Minerals, I will not dwell on it. There's a huge list is there. I have listed just important ones. I will not mention the copper, zinc. There is no need to remember it. No one has ever become rich by memorizing all these figures. These charts are available, and just go through the charts and do your job. But of course, important ones, calcium, phosphorus, you have to remember, it's in millimole per kg. You can convert into milligram per deciliter, what we normally do. Iron, I would like to just mention a few points. So we all practice delayed cortical emptying, and it has benefits. We now recommend iron at 2 to 3 weeks of age, and they are studied between 2 to 3 and 4 to 8 weeks. There is less need for blood transfusion. So the ESPGHAN say level of evidence is 1, grade A, high quality recommendation. Start daily iron intake of 2 to 3 milligram per kg per day at 2 weeks of age for babies below 1.5 kg. We all agree? Yes, no problem. We do all kinds of investigations. Do we do ferritin in NSU? Nowadays, we have started doing exome sequencing, targeted in exome. How many people do ferritin levels in neonatal unit? Can I have feedback from the audience? कितने लोग ferritin करते हैं? अरे उसमें कोई मैं कोई प्राइज नहीं देने जा रहा हूँ या कोई हैंग नहीं करने जा रहा हूँ, बंदे को करते हैं तो बोलो, नहीं करते तो नहीं करते हैं, दैट्स ऑल फाइन. कोई करता नहीं करता है, नहीं करते ना, okay, that's good. Well, Anup comes from very reputed institution, and so वो लोग कर रहे होंगे. That means we do it very very infrequently. Yes, I'm coming to it. But मेरा कहने का मतलब है कि जब हम एक्सोम सीक्वेंसिंग 15,000 16,000 वाला कर रहे हैं, फेरिटिन कैन बी 200-250 रुपए में जाकर के कैन बी डन. So ferritin concentration below this level indicate iron deficiency, and above 300, I'm concerned with above 300 indicate iron overload. And the last line, the ferritin is below 300, above 300 microgram per liter, which is same as microgram per deciliter or per ml. Sorry. So iron supplementation should be withheld or discontinued until serum ferritin falls below this level. So if the ferritin is above 300, don't give iron supplementation. But what is our recommendation? Starting at 2 weeks. So that prompted us to look into this matter. So the study is still ongoing. Serum concentrations, ferritin concentrations in preterm babies. This is just a preliminary data. Till now, we have enrolled 70 babies. Mean gestational age is 32 weeks, 1600 grams is of birth weight. Sorry, I'm not given plus minus standard deviation. Look at the serum ferritin values at 2 weeks of age. How much is serum ferritin? 600. 4 weeks, 460. 6 weeks, 427. And ESPGHAN says if the serum ferritin is above 300, don't give iron supplementation. So almost 90% of the preterm babies, stable, growing preterm babies, had serum ferritin above 90%. At 4 weeks, 1/3 had it. At 6 weeks, 12% had it. So measuring serum ferritin may be useful to fine-tune iron supplementation. This is, of course, my personal opinion. It needs to be validated. So I want other centers. This is a simple cross-sectional short-term follow-up study. You can do it, but don't do it very fast. पहले मुझे अपना data publish करना है ना? So let us complete it next 3-4 months में आकर के उसके बाद. But please do it. We need data from different units. So is it a good practice? So the problem क्या हो रही है हमारे यहाँ की babies 3 weeks or 4 weeks, serum ferritin 500, and the resident might go to resident setting. Sir क्या करें, iron दे ना दे बच्चे का, hemoglobin 8 है, and the ferritin is 800. If you look at thalassemia, ferritin more than 1000 is indication of iron chelation therapy. Some of the babies are ferritin of 1200, 1300, 1400. So it's a difficult task for a consultant. I have to calm down them. Just wait. It's a hyporegenerative anemia. It will recover after some time. It will take some time, but we need more data and more sample size. So let's see what happens. Right? Now coming to the minimal enteral feeding or trophic feedings, small volume feedings without increment for 7 to 3 days. As such, no clear benefit of trophic feeding of any duration compared to advancing feeds immediately after birth. So that means you start trophic feeding on day 1, you can increase on day 2, day 3, day 4. That's fine. But historically they defined it either you keep the same level for 3 to 7 days and then you increase it. ESPGHAN say the small volume feeding should be started on day 1 or soon after birth in most preterm babies, and advanced feeds as clinically tolerated. So look at the baby. Don't forget the baby. Don't be under the influence of guideline or theory that it can be increased mindlessly, or you have to see the baby is doing well. Advancement of enteral feeds after 4 days of life, faster progression can be done, right? Meta-analysis showed that faster increment of enteral feed volumes positively reduces the time to reach full enteral feeding and the length of hospital stay. But these are short-term outcomes again. In stable preterm infants, where the clinician considers that the feed volume can be increased, a daily increment of 18 to 30 ml. So range is there. You don't have to adhere to a 30 ml strictly. Is 18 or 20? Yeah, I'm not happy with 18. 20, 30 ml is easy to remember and easy to say, but that's okay. Angrejo ne kaha 18 ml, so I would say 18 ml. Especially in the breast milk fed infant, great recommendation, high level of evidence is there. Right. Gastric residuals. Well, we have not stopped doing it, but historically for 30, 40 years in BHU we did it. They were commonly used for defining feeding tolerance, but no consistent definition. Gastric emptying is influenced by so many factors, type of enteral feed. Of course, with breast milk, gastric emptying is faster. The shorter, twice, duration is less compared to formula fed babies. So routine monitoring of gastric residual increases the risk of feed interruption because there is some 3 ml, 4 ml, and then you end up what to do. Time taken to reach full volume feeds and again birth weight and more duration of parenteral nutrition. But it does not have impact on necrotizing enterocolitis incidence. That is as per Cochrane's review. So routine monitoring of gastric residuals in stable infants is not recommended. But if there are problem abdominal distension, you are suspecting neck, then of course you can go for it. No one prevents it. Feeding mode, orogastric versus nasogastric. Historically, we were doing nasogastric. For last few years, we have switched over to the orogastric feeding. There are theoretical disadvantages of nasogastric feeding, but systematic reviews show no consistent effects on feed tolerance, whether you use OG or NG, or incidence or frequency of apneas or desaturation episodes, or bradycardias. Orogastric tubes, the common, whenever you take the unit, sometimes they are displaced, they are coiled up. Nasogastric are more stable, but we are using nowadays orogastric feeding, rarely nasogastric feeding. Sometimes baby comes from outside, they are on nasogastric, but our default mode is orogastric feeding, right? Bolus versus continuous feeding, again a controversy. Bolus feeding has improves cyclic perfusion, but systemic review shows longer time to reach full enteral feeding using continuous rather than intermittent feedings. We all eat food intermittently, not we. We are not taking morning, evening, not continuously. Except fetus who are getting milk and whatever the nutrients 24 hours a day. In postnatal life, all human beings, all animals, they take food intermittently. So I would be the evidence is in favor of intermittent, but people have used continuous feedings. Fat loss may be a little bit more with the continuous feeds, but no effect on growth. And the data on apnea is inconsistent. We follow intermittent feeding, bolus feeding. 2 hourly, 3 hourly. Historically, we were doing 2 hourly. 10 or 15 years back, we switched over to 3 hourly. Not much difference, but low quality evidence suggests that feeding 3 hourly is comparable to 2 hourly feeding. But very, very tiny babies may be better with the 2 hourly feed. One benefit is there of 3 hourly feed. It reduces the nursing workload. And when we analyze this too early feed around 10 or 15 years ago, truly speaking, the too early feed means 12 feeds in 24 hours. So when we analyze staff nurses charter, those charts, the baby were getting only 10 or 11. So if they're getting only 10 or 11 instead of 12, why not say 3 early? And most babies are doing well. We have not found any difference. But the workload is much less. There is no doubt. So this is our little bit experience. I mean, full volume feeding versus small volume feeding when babies below 1.5 kg, still unpublished, completed last year. Birth weight was 1,000 to 1,500 grams, 1.99 grams. We had this exclusion criteria: hemodynamic instability, delivery room resuscitation of over 1 minute, baby is too sick, reversal of anti-stolic and major congenital malformations. Our primary outcome variable, I would not say it's a great outcome variable, but short-term variable, the incidence of extrauterine growth restriction, which were defined as, that parameter below 10 centile or get score below minus 1.2 ST, as per intergrowth 21st reference. We randomize baby within 24 hours, not at 1 or 2 hours or 3 hours or 4 hours. It may be difficult. Baby is fine at 1 hour or 4 hours, baby becomes very, very sick. The problems are there. Some people have randomized at 48 hours basically. That will be a better strategy because of open label trial, we could not do that blinding kind of thing. We have a range of secondary outcome variables: late onset sepsis, feeding intolerance, NAC, time to regain birth, mortality before hospital discharge, length of stay. And you see, all are short term. There is no long term. That's the problem in our studies in general, right?
5 minutes.
Okay, I'm coming to. So feeding volumes, full volume 80 ml, small volume we started with 20 ml. Maternal characteristics were broadly comparable, no issues. Neonatal characteristics also broadly comparable. Look at the primary outcome variables. Weight, 93% baby were growth restricted at this full volume. Small volume, 75%. All babies, whether you give small volume or full volume, there were no difference on the growth outcome. This is what we found. Look at the secondary outcome variables. The last line. What did you find? Do you find something problem? This is my shocker again to me. More mortality in babies who were given full volume feeding. Number is small. Our target sample size of 180 to 100, but then we terminated early because of this interim analysis. 27%, whatever the case, died. Full volume feeding group, small volume feeding group. We learned there were no benefit on growth outcomes and higher mortality. The trial was terminated. We informed of ethical committee. Open label trial, but risk of bias influencing outcome was unlikely because the dominant philosophy of the unit at that time was to give more feeding. So, we were giving kind of open feeding kind of thing, like full volume feeding. The full volume feeding started on day 1 of age may not be safe to the babies. Mechanism, we do not know, but I will dwell on it next. Limitation, small sample size, no long-term outcome. We could not exclude residual confounding. So let us learn from the adult literature. Shushma, I want your attention on this slide because next you will be taking on full one. So although the numerous observational studies, I'm talking about adults and children, observational studies, they should underfeeding the poor outcomes. Recent randomized controlled trials in adults and children show that early full nutritional support does not benefit critically ill adults or children and may induce dose-dependent harm. There are studies and studies and studies and studies in adults and children, and they show that full feeding did not benefit adult and pediatric ill patients, and some even showed harm. So the most recent European guidelines for adult critical ill patients shifted from promoting full feeding to so-called permissive underfeeding in the first week of life, and no large-scale RCT in critical ill patients have found benefit of early. I'm talking about adults and children, right? But मुझे 2-3 minutes और दे दो जाकर, because it's the crux of my slides, right? So what could be the harmful effects of full feeding? So when we become sick, what happens to our appetite? What happens to our appetite? Increases. And this is a universal phenomenon. I'm not talking of human beings. This is not animal kingdom, both vertebrates, invertebrates. That's it. Anything is happening in throughout animal kingdom, loss of appetite or anorexia. That means it's an evolutionary in terms of mechanism which might have survival advantage for the fish. So suppression of the fasting-induced recovery. I mean, if you suppress this fasting-induced recovery pathways, it can suppress the autophagy, which is a crucial process for recovery from critical illness. It will also suppress ketogenesis, so availability of nutrients, and ketogenesis, ketone bodies are not only nutrients, they are involved in so many biological pathways. And there is anabolic resistance. Why that means during acute illness, whatever you feed, there is anabolic resistance. That those nutrients are not going to be utilized for new muscle synthesis or protein synthesis. This happens for 5 to 7 days. I'm just coming to it. So aggressive feeding, is it a good idea? Well, if I say giving of aggressive oxygen, is it a good idea or bad idea? Okay, if I go for aggressive, what was the other example? Alright, aggressive ventilation. Would you go aggressive ventilation? You go by gentle ventilation. Even in duty and BTS curriculum, the topics are being shortened because they are too much of overload. So anything aggressive is bad. I think no one likes it. Being moderate is always good. So it may or may, I would call it overfeeding. It may or may not be. Some babies may derive benefit, some may not be benefit to. So we need a phenotyping of preterm babies, and maybe artificial intelligence can help us. Clinically, it will be difficult. So you need technology to identify babies who will benefit from full volume feeding and babies who will not benefit. Current evidence has raised some questions on this strategy. May not provide benefit and may expose patients to harm. Only a large scale trial can give a definitive answer. So this is my final slide, my final answer. Larger or bigger is not necessarily better. Small is beautiful. I think there was a book, I think 60, 70 years back, written by some Angrez army. There are situations when small may be better or big. Hold on, lady, for 1 minute. Keep in mind the risk of overfeeding or aggressive feeding in this vulnerable population. Do not starve the babies. That is my purpose. If you starve babies, start feeding, there will be refeeding syndrome and higher mortality. So start profit feeding on day 1 with human milk and increase as per tolerance, and consider local context and individual infant while adopting guidelines. Thank you very much. And I would be happy to respond to any questions.